examining the adnexa using simple descriptors. We look at the role of iota simple descriptors in examining the adnexa after the introduction and before we run off. The learning objectives are to know the iota simple descriptors and, most importantly, to apply the simple descriptors in clinical practice. This paper looked at histopathology pattern of ovarian tumors in a hospital, and as one can see here, functional cysts made up 39% of the lesions that were surgically managed. All these follicular cysts, compositing cysts, hemorrhagic cysts are physiological cysts that can resolve spontaneously. But all these patients underwent surgery for conditions that will certainly resolve spontaneously. Look at this age group having the highest as expected. When talking about the easy descriptors, we need to use standard terminology. For the purpose of this presentation, we are going to use the terms definition as measurement to describe the sonography features of adnexa, a consensus opinion from the International Ovarian Tumor Analysis Group published in the year 2000. Up to 10% of women will have some form of surgery during their lifetime for the presence of an ovarian mass. Interestingly, approximately 10% of suspected ovarian masses will ultimately turn out to be non-ovarian in origin. Unfortunately, most ovarian lesions in premenopausal women are benign. The modified simple descriptors can diagnose at least 40% of adnexal masses, and correct diagnosis is made in about 99% of cases. For the malignant descriptors, the performance is 93 to 96%. So let's look at the simple descriptors. Now, if you look at these images, I believe that we all know who these people are. How do you know that this is the great Muhammad Ali? We know that this is Mandela. We know this face probably because of the recent conflict. And we all know the current empire and the empire that is trying to upstage the current empire. So, simple descriptors are actually based on pattern recognition. When you see certain features, you will know that this is likely to be A and not B. Secondly, you don't need a computer to use the simple descriptors. There are 4 benign simple descriptors and 2 malignant descriptors. The 4 benign descriptors are benign simple descriptor 1, which is a unilocular cyst with ground glass echogenicity in a premenopausal woman. This is highly suggestive of endometrioma. Benign simple descriptor 2 is a unilocular cyst with mixed echogenicity and acoustic shadows. Unilocular cyst with mixed echogenicity and acoustic shadow in a premenopausal woman, suggestive of benign cystic teratoma. Benign simple descriptor 3 is a unilocular cyst with anechoic contents and regular walls. A unilocular cyst with anechoic contents and regular walls, suggestive of simple cyst or cyst adenoma. And benign simple descriptor 4, all unilocular cysts with regular inner walls. All unilocular cysts with regular inner walls. Example, hemorrhagic cyst. So these are the 4 benign simple descriptors. In 99% of cases, the diagnosis is likely to be correct when this is used, and it detects 40% of adnexal lesions. For malignant descriptors, you have malignant descriptor 1 and 2. Malignant descriptor 1 is lesion with ascites. Lesion with ascites and moderate color in a postmenopausal woman. For malignant descriptor 2 is lesion in a woman greater than 50 years with CA 125 greater than 100 units per mil. When you have both benign and malignant lesions, the mass cannot be classified. In modified benign simple descriptors, it only considered lesions less than 10 centimeters. When the lesion is less than 10 centimeters, the risk of malignancy is less than 1%, as can be seen here. So if you have unilocular cysts, you can see the risk of malignancy in pregnancy, outside pregnancy, less than 1%. As the complexity increases, not as in complex mass, because we do not use the word complex mass in aorta palus, but the complexity of the lesion from multilocular cyst to unilocular solid to multilocular solid and solid. As the complexity increases, the risk of malignancy also increases. So these are the benign simple descriptors: endometrioma, dermoid or mature cystic teratoma, simple cyst, cyst adenoma, hemorrhagic cyst. For the 2 malignant descriptors, remember, tumor with ascites in a postmenopausal woman are moderate flow. When such is found, 96% are malignant. When the CA125 is greater than 100, in a woman who is greater than 50 years, the risk of malignancy is 93%. Remember that modified simple descriptors do not apply when the lesion is greater than 10 centimeters. Here you can see this lesion greater than 10 centimeters. Of course, it turned out to be mucinous cyst adenoma. Here, more than 10 centimeters, it turned out to be serous cyst adenoma. But modified simple descriptors do not apply when the lesion is greater than 10 centimeters. Now let's look at the 3-step strategy. When you use the simple descriptors, you'll be able to pick or accurately diagnose at least 40% of adnexal lesions. If that doesn't apply, use the simple rules. And when the simple rules is used, you can pick up to 75%. So you are left with about 25%, where, among others, you can subject it to assessment by expert, which is the best. In a 2-step strategy, which is now recommended, you apply the modified benign simple descriptors with the lesion less than 10 centimeters. If you can classify, go straight to Adnexa model. So let's look at a few case examples. This was a 30-year-old Noripara who had bilateral cystectomy 4 years prior to presentation for endometrioma. She now presented with a 2-month history of lower abdominal pain, infertility, and painful cyclical periumbilical swelling. So, not the unilocular cyst in a premenopausal woman with ground glass content. So this was a case of endometrioma. But here you can see on the other ovary, you have a multilocular cysts. Look at the all eye appearance here because of adhesions. Here you can see the uterus, and look at this question mark sign, suggesting that there is pouch of Douglas obliteration. And at laparotomy, what was found was frozen pelvis. This was a 32-year-old multipara with a 7-year history of lower abdominal pain. She was seen when she was 29 with a small dermoid, but at this time, not the ultrasound image on one ovary and the other ovary. And look at these tiny globules that looks like ultimately probably may develop into the typical chocolate truffles, which is near pathognomonic of mature cystic teratoma. Here, not the floating fat globule and the thick wall of the mature cystic teratoma. Case 3 was a 30-year-old at 25 weeks of gestation. She presented with recurrent lower abdominal pain of 5 years duration, for which she was treated with antibiotics at various times. Look at the ultrasound image. What looks like ground glass content, but again here you can see some lacy pattern here. And look at this echogenic area within this is floating literally. Here look at the placenta, fundally located, fundus. But look at these adhesions between these cysts and the fundus of the uterus. And look at it. This is the lesion, the fundus of the uterus, and the adhesions. In the course of the surgery, the cyst ruptured, and what came out was pus. So this was a case of infected dermoid, which was not actually suspected. When you go back to the history, this history of recurrent lower abdominal pain treated with several antibiotics gives it away that it could be infected, but that was missed. A running point, really. This was a 49-year-old multipara presented with a 9-year history of lower abdominal pain. Look at this cyst, clear content, but the cyst was centrally located, and malposition actually is a feature of torsion, as was seen at surgery. Was a 22-year-old primipara who presented with a 1-week history of lower abdominal pain, which wasn't 3 days prior to presentation. Now, not this edematous ovary, which appeared like a solid lesion, and not this cyst with crescent sign, suggesting that it is an intra-ovarian cyst. So, this was torsion as a result of hemorrhagic cysts. Benign, simple descriptor 4. In the case of dermoid, you can see here a mesh in fat. Here you can see the typical ground glass appearance, the dermoid. And here look at this pathognomonic feature of mature cystic teratoma, what others describe as chocolate truffles. Again here, this is a case of multilocular dermoid with Rokitansky nodule, and this is intralesional dermoid, which cannot be picked by laparoscopy. This was a case of hemorrhagic cyst using transabdominal imaging. Look at the J-like movement on applying pressure. Do not move the tissue, do not move this way. Again, another case of hemorrhagic cyst with cloth retraction. Here you can see hemorrhagic cyst with fishnet appearance. This anechoic regular wall, hemorrhagic cyst with cloth retraction. Again, hemorrhagic cyst. This patient was seen in the first trimester acute lower abdominal pain, and not this color flow, a typical ring of fire. So corpus hemorrhagicum. Another case, as can be seen in the first trimester, corpus hemorrhagicum, and all these are cases of mature cystic teranoma, benign simple descriptor 2. Pitfalls using the simple descriptors. Look at this ovary here, and look at these cysts. Not this crescent sign, suggesting that this is intralesional. But if you look at this area closely, it is more of edema than solid tissue. So early on hemorrhagic cysts can be diagnosed as a solid lesion. One thing you can do, apply color. Hemorrhagic lesion will not take up color. The same thing, this was a case that was misdiagnosed as a lesion because of this, what looks like a solid lesion. These ones are actually artifacts. So again, hemorrhagic cyst. This here looks like a papillary projection, but this is actually clot retraction from hemorrhagic cyst, not papillary egression. Again, this case was misdiagnosed as a case of dermoid, but look at this retractile clot. And of course, it was confirmed surgically to be hemorrhagic cyst. Now, these are cases of hematocolpus because of imperforate. I beg your pardon, because of transverse vaginal septum. So, you can see this is also ground glass, but it doesn't make it an endometrioma because the pathogenesis is the same. Again, here, endometrioma with a sludge. The endometrioma here is multilocular. So again, going back to the 3-step strategy. Simple descriptors. In this case, this is modified benign simple descriptor 4, or unilocular cysts with regular inner walls less than 10. Example, hemorrhagic cyst. So this is hemorrhagic cyst. So the simple descriptors has actually defined what this lesion is. So will you go on to subject this to simple rules and subjective assessment? No. Why? Because the simple descriptors has already classified this as simple descriptor 4, which is hemorrhagic cyst. Here you have a solid tissue. Can you use simple descriptors for this? No. This is not a unilocular cyst. So modified benign simple descriptor cannot be used for this case. So simple rules was used, and this was a malignant lesion because there was presence of M1 and M5 with no B features. So simple rules has already classified this now as malignant. So do you need to subject this to expert opinion? No, you don't. Why? Because simple rules has already classified this lesion as malignant. Looking at the 2-step strategy, which is recommended. In this case now, modified benign simple descriptor, will it apply here? No, it will not apply here. Why? Because this is a solid lesion. So what do? You move straight to Adnexa model. What about this? Will you apply modified benign simple descriptors? Yes. Why? Because this is a unilocular cyst with ground glass echogenicity in a premenopausal woman, which is also suggestive of endometrioma. So the modified benign simple descriptor has already classified these tumors. So there is no need going for Adnexa model. So our take-home message is that knowledge of IOTA terminology is key in the current management of ovarian masses. Modified simple descriptors can diagnose at least 40% of nasal masses, and correct diagnosis is made in 99% of cases. The performance for malignant descriptors is between 93 and 96%. It's important for us to note that both follicular and hemorrhagic cysts are always unilocular cysts. Thank you.